Yeah, thank you for the introduction, and thank you for the organizers for inviting me to participate. So I'm going to be talking, I have a number of irrelevant disclosures, but doesn't hurt to be too careful. So what I'm going to do in the next 15 minutes is to go through sort of why we stress about lesion detection in epilepsy, go through some challenging detection problems and their mimics, and then focus in a little bit on subtle variations in gyration and using diffusion as a problem-solving tool. And through all this, I'm going to try to strike a balance between boring you with things that are obvious and frustrating you with things that are impossible to see. Hopefully the handout, which has PDFs of everything I'm going to show here, will help. And the handout also has additional examples that I won't go into in further detail. So the importance of lesion detection is that, well, first of all, generally we're talking about malformation of cortical development as the single largest big group, and then within that, focal cortical dysplasias are the most prevalent histology. Importantly, about a third of them are considered non-lesional, at least on initial MRI review. And the importance of the lesion detection is that it directly relates to the likelihood of a good outcome from surgery. So if you look at group analysis of epilepsy surgery as a whole, it has pretty good outcomes, including for malformation of cortical development. But when you have a non-lesional case, the likelihood of a good outcome is worse. And there's less data for very young children, but it's likely to also be true. And it's also true even in the era where we're doing a lot of stereotactic EEG, where you can potentially get a lot of more detailed invasive monitoring data. So being able to detect these makes a great deal of difference to the patient, and which is why we stress about it. The lesion location, there are a lot of nice papers that have kind of depicted the topography of these lesions. They're not random, so they tend to occur in certain locations. That's the first thing. And the second thing, that interacts with their resectability, which is directly related to their likelihood of seizure freedom. So for example, type 2B cortical dysplasia, precentral gyrus, going to be hard to resect that without a lot of morbidity, and so there's a increased likelihood of seizure residual. So in the best case, possible case, you're going to have something like this, where you have a very high quality MRI, a myelinated patient, there's no marring artifact, and you have the things that you expect, which is regional uniformity and gyration and cortical thickness, gray-white matter differentiation. And in the ideal case, you will have something obvious, like a very large cortical dysplasia as shown here, or you'll have one of the pathognomonic imaging presentations of cortical dysplasia that are highly associated with specific histologies, like the transmantle sign, which we've discussed already, or the bottom sulcus dysplasia, which is also like the transmantle sign associated with type 2 cortical dysplasia and mTOR pathway alterations. And just as a quick reminder, even though these are highly associated with specific histologies, they're not 100% specific. So this is an example of a precentral gyrus focal cortical dysplasia type 2B, which obviously doesn't have a transmantle sign. I would argue doesn't have a bottom of sulcus sign either. So where things get hard is when you have something that's non-obvious. So that's illustrated by the next two cases, where you have a patient with intractable seizures manifesting as behavioral arrest. If you don't have any clinical information, some of you may clue into something, but a lot of people wouldn't, and that's quite okay because this is a subtle finding. But once you subject them to a long-term monitoring admission, you can see that this person had auditory aura and they had left temporal onset. And with that piece of information, you can focus in on the left as opposed to the right Heschel's gyrus, and you can see that there's subtle smearing. This turned out to be a cortical dysplasia type 2A with good outcome. Conversely, you can have things that are obvious but misleading. So in this particular instance, you had something that kind of looks like a transmantle sign. They had generalized tonic-clonic seizures preceded by nausea. On long-term monitoring admission with ictal and interictal SPECT, there was hyperperfusion during seizure in the left temporal lobe, and they found out that there was electroclinical seizure arising from the left temporal lobe. This turned out to be a radiographically occult type 3A cortical dysplasia, which even retrospectively you can't see. So the previous finding, the only finding really radiographically, was misleading. And this is all just to say that clinical correlation is essential. When you do these epilepsy surgery conferences, they're seeking convergence of electrographic, semiology, and imaging data. And this directly relates to how we read these things. So First of all, the pretest probability is going to impact the kind of read you have. You have things on the bottom left-hand corner here, which are basically the clinicians all but telling you they think this is not a seizure, but they're doing it anyways. And so, like there'll be a lot of like paragraphs about social situations and stuff like that. And then on the other end, you have like something that's highly unusual, specific semiology. It's reproducible and always has a specific EEG abnormality. And so things on the right here, you're going to stress about a lot. And if you don't see something, you're going to get even more stressed because you know that if you call it normal, you're either going to get an email from the clinician or you're going to get an email from the person who does epilepsy surgery conference, which in our institution is Sanjay. So, and this also impacts how we read. How we read it also impacts the surgical options in terms of the probability we assign a lesion if it's not something obvious, the definition, the borders, and whether it's in a sensitive location. So for example, in this highly likely, lesional epilepsy situation, if there's a well-defined lesion, non-eloquent structure, that's going to typically go single-stage resection, maybe with electrocorticography. If it's a subtle finding, you can't really draw a line around it, it's someplace sensitive, that will usually end up getting stereotactic EEG or some sort of invasive monitoring prior to the actual resection. So what happens is that then when you're looking for those subtle things that are non-obvious, you start to get potentially faked out. And probably the most common source of this, in my experience, is the so-called bias field inhomogeneity. So you have a multi-channel head coil, which you're trying to maximize signal to noise, but it has some regional variations in signal. There's also low-frequency noise, and so there will be gradations of signal. So if you focus in on something like, for example, the right temporal lobe, you might say, well, this is a little brighter than the other side, and there's some haziness as well. So maybe I'm going to stress out about that. But then when you harshly window it, you see that there's actually some gradually varying signal intensity across the image, that it's bright in this area on T2 and flare, but it's also bright on T1. And so this form of artifact usually is recognizable by its kind of subtle gradation, and it usually has kind of a sinusoidal look to it. It doesn't usually follow brain anatomy, and in many but not all cases will affect T1 and T2 equally. So this can still undermine your confidence. So this is a case where there was a patient who had left temporal lobe seizure. There was some thickening of the cortex here, and there was some obvious shading artifact or bias field inhomogeneity. So how do we deal with this and increase our confidence? Probably the best or most interesting way of dealing with this is a kind of more elaborate form of the typical MP RAGE sequence that many of us use, which is called MP2 RAGE, and it's basically a technical means of canceling out the bias field inhomogeneity by doing 2 inversion times. And that was done in this case. So you can see that on the MP2 RAGE, the signal is uniform across the image, and you still see the thickness and the smudginess. You can also choose one of the inversion times such that at 50% gray matter and white matter signal equals 0 signal intensity, so it's black, and you get this etching artifact. And you can see that this zone of transition is wider on the left than the right. So in addition to this, there was PET hypometabolism, and this was resected. Having said that, the one caution with overinterpreting these things, in addition to bias field inhomogeneity, is myelination. So we usually think of saying myelination after age 2 is sort of mature, but that's kind of a first approximation, because if you look at a lot of juveniles, like 2 to 5 years of age, for example, you'll see that the terminal myelination, the subcortical white matter, the temporal and frontal lobes, is often not 100% complete. And that's illustrated here, where if you look at the temporal lobe here, this looks smudgy. So if I just showed this in isolation and told you this was like a cortical dysplasia, you would probably believe me. I mean, I'm standing up here, so I guess you believe me, regardless. But the thing is in this case, it's symmetric. So it turns out that this was not anything to worry about. This patient never had a seizure after this one-time event, and again after the seizure. And so you have to be able to look at use symmetry to help you. Similarly, on this case, there is fuzziness in this 5-year-old with seizures that is in the subcortical white matter on the right side on flare, diffusion, and T1, but on the left side, it's subtly increased. So in this particular instance, you can't completely dismiss it, and the seizures the patient were having were coming from this general region. So this is a situation where it was subjected to stereotactic EEG. They saturated the area with electrodes, and they determined that there was electrographic onset from this thing, and they decided to laser ablate it with a good result. Myelination is something we have to uniquely deal with as pediatric neuroradiologists, and the impact on lesion conspicuity, in my experience, is a little variable. So you can't just say, just wait till they're more myelinated and for sure it's going to be more obvious. So that's illustrated by this patient with infantile spasms at 2, 15, 24, and 32 months. And you can see that it's actually, to me, most conspicuous actually at this 15 months when the intermediate myelination is interacting favorably with the actual lesion signal intensity, becomes less obvious later on, but still visible. And this is, again, just another instance of this MP2 RAGE first inversion, also called edge imaging by some people. The myelination can also be an important clue towards areas that you should look at in particular. And I think this was first pointed out to me by Ellen Grant and Sanjay Prabhu, where in this case you have this area of volume increase in polymicrogyria in the left frontal lobe, and then you look at the internal capsule and you see that there's accelerated myelination here. So sometimes the myelination, differential myelination is pointing you towards a particular area of concern, and that can be useful when it's present. Then we have to also consider blind spots, and there are several of these. I have some in the handout that I'm not going to go through here, but maybe one of my favorite ones is this so-called sphenoid cephalocele. They're not true through and through bone cephaloceles. These are really, they look like arachnoid pits that are have brain stuffed into them that gets encephalomalacic, and they can cause a lot of seizure, and it's a described phenomenon. And these can be very easy to miss, particularly on 2D images. And you actually have to specifically look for them. In this particular case, there's this little area of cystic encephalomalacia that's being stuffed through this bone defect in the left temporal bone, and sphenoid bone rather, and this was resected with an excellent result. So yeah, I always put, it's actually in my macro just to look here because it's, well, there's a long story, but basically there's a tendency to overlook these things, and in this particular instance, this was a Saturday call case, and I didn't sign it till Monday, at which point I called it, normal, and then like as I often do, like 2 minutes later, I'm just looking at it again, and I indented it because I realized there was this thing, and this obviously in this particular patient made a difference. So it also points to the fact that you shouldn't rush into final site anything. And then subtle gyration differences. If you read a lot of pediatric imaging, you're very accustomed to what normal is, but if you're not, then you have to have some ability to reference something. So this one over here is just diffusely abnormal, but you could forgive someone who doesn't read a lot of pediatric imaging as kind of like just kind of being intimidated by the fact that it's just unmyelinated. But once you go to a normal control, you can see that the gyral frequency is way up. And similarly, with a lot of these mTOR pathway entities, you will have increases in gyral frequency, which can be relatively subtle. This is a MCAP syndrome patient, but perhaps like P10 hamartoma syndrome, these patients also can have very subtle polymicrogyria that you have to have good quality imaging in order to detect. This is a patient with infantile spasms where it's kind of the opposite situation, where at first pass you might say, maybe this is normal, and then basically, I went back and forth on this. I first said, I think it's normal, although I acknowledge that this is kind of, increased in frequency. Then I said, okay, it is decreased in frequency. And then this, I was like, it's a little iffy. And then I did the second time, like, okay, this is not normal. There is this entity that this happens in. And you can see here, just compared to an age-matched control, the gyral frequency is decreased and it's thickened. And this is a attenuated form of pachygyria that's kind of typical of this disorder. And I've seen it twice. I mean, I've called it maybe 6 times, but it was true at least twice. So I think that's not bad. Gray matter heterotopia is diffusion is a really good tool because it's gray-white matter differentiation, things pop out, and so that's illustrated by this case. We have a lot of nodules from TS, which are clearly not diffusion abnormal, and then you have the gray matter heterotopia, which is abnormal. And the key thing is that it has to follow gray matter on all signals. So this case, in addition to the caudate tail, there's a little gray matter heterotopia, and it's following gray matter signal on diffusion. On this case, it was an outside hospital. They called this gray matter heterotopia, but they came back a year later, and this was actually a mass. And the key here is that on the ADC and the T2, it doesn't really match gray matter. And the last thing I'll leave you with is that caution's warranted for things that are the working diagnosis is cortical dysplasia, but it doesn't have a pathognomonic morphology like a transmantle sign. So that's illustrated by this case. This patient is a good student, had seizures that were well controlled. He was getting intermittently imaged for a period of 10 years, went to college, had a breakthrough seizure, and got re-imaged for the first time in a few years. And you can see that this area of flare hyperintensity, there's a little focal T2 hyperintensity, and at this point it becomes a more defined thing and it's enhancing, so it's presumably low-grade tumor. And just to make things more confusing, some things can be transmantle in configuration but still tumor. So this was a low-grade glioma that had superimposed mTOR low percentage mosaicism of a pathogenic mutation. And this is a classic V600E mutation in low-grade glioma, but it also happens to be transmantle in configuration. So I will leave that here because some of these future direction things probably will be covered by Mai-Lan Ho. And I thank you for your attention.